Everybody, good afternoon everybody, and it's very lovely to be here from South Africa in your beautiful country and speaking to all these beautiful people. And today I'm speaking about the elephant in HIV care. So that is that big important issue that everybody's trying to ignore, and I'm hoping to bring that very firmly into the room today, and we're very privileged that they've made time to have this panel here as part of this symposium. So firstly, I would like to bring the paradigm or the perspective that I'm bringing, and I do a lot of teaching in sexual health, both to teachers, doctors, students, community members, and I want to just remind us all that every one of us that is sitting within this room, you all have your own cultural ideas, religious ideas, political ideas on sex, on sexual orientation, and on gender diversity. And those ideas are very much determined by what your particular religion, or political ideology, or cultural, or how you have sex determines a little bit on how you think about sex, and that's perfectly fine. But when our patients or our clients or our adolescents come into our rooms, they are not necessarily like us. And I think one of the things that we need to work as health professionals and be mindful of is that we need to be aware of that tension. And I think we do have a superpower as clinicians, that we are able to have our own perspectives, have our own particular ideas and beliefs that we have at home, and still be able to be accepting and affirming of one another. And this principle is often getting eroded in the world of today. In South Africa, this was an amazing study that was done in 2016 by the Human Sciences Research Council, and I just want to highlight one thing. They were looking at the attitudes of South Africans towards our LGBT community. And interestingly, it's found that 51% of South Africans did believe that gay people should have the same rights. They should have constitutional rights and protection, which we do have in South Africa, even though 72% of that same group believe that same-sex sexual activity is morally wrong. And I think that shows what we are able to be as clinicians, as NGOs, as community members. We are able to bridge that gap between this is where I'm at, and yet I'm providing services to a community. And I would like us to be mindful of that as we go through some of the things that we've been doing in South Africa. So a question we often get asked in our settings within transgender care in South Africa and in Europe especially is, why is there suddenly so much more talk about transgender? When I grew up at school, we still hardly even talked about the gays, but now why suddenly is this so much? And I think a good way to look at it is the history of left-handedness. Right, so in 1939, only 2.1% of the population was left-handed, because in those days, being left-handed was not cool. There was a whole range of educational things that was done to make sure you were not going to write with your left hand. Then, of course, the neurologists and the neuroscientists and the psychologists discovered, no, well, actually, it's damaging to try and force people to write with their right hand if they've been neurally wired to write with their left hand. And so the science changed, and by 1972, we now know that about 12 to 14% of the population is left-handed. And we'll see a similar thing with trans. So in those countries where it's accepted, we now see a larger percentage of people presenting as transgender, and that's a pretty set percentage across the board. In countries, obviously, where it's illegal or where it's still frowned upon, you will have much lower rates. So one of the things that's happened in the science and in medical science is our understanding of why some people are transgender has really transformed in the last 10, 20 years. And we now understand how the brain gets wired before you are even born. In the first trimester, as you know, your testes and your ovaries and all your bits gets made. And in the second trimester, we have the neural networks gets laid down of your prefrontal cortex. So this is the part of you that your personality, your identity all lies within this higher part of your brain. And we know there's about a 40% genetic input in terms of you having a neural network that will predispose you to being transgender. And then, of course, there's hormonal and all kinds of other influences, as there is with all parts of our personality. So pretty much by the time you are born, that neural network that predisposes you to a certain gender identity has already been laid down. But of course, when you are born, it doesn't mean that that is already, we're not self-aware yet. The prefrontal cortex is still completely asleep when we are born. And it takes 23 years, as Prof. Becker has showed us, for that whole area to mature. And there's a few key sort of awakening points. So specifically around the age of 8 or 9, our prefrontal cortex comes online, it becomes available for activity. It's still not completely mature, but you'll often have children at this age suddenly having a concept of self. Who am I, and why am I like this, and why is this my name, and are these my parents, and why is there death, and I'm starting to get phobias. And we have an awakening to ourselves around about that age as this higher identity part of ourselves come in. By about 12, 14, already 70 to 80% of the prefrontal cortex is mature. And adolescents are very able to have, for example, empathy, to have self-awareness, to have self-control, and they just need a bit of support and time to be able to actually make higher decisions, but all of the engineering is there and up and running. But what does also happen is the body starts to change, and you start having all these sex hormones playing in. And so it's at different ages where people will start becoming aware of their own identity and having an experience that the identity that I am, who I am, is not the same as the body that I was born with. So transgender, for those of you who are still a little bit vague on the terminology, is somebody who was, for example, assigned female at birth, that's what the midwife said, it's a girl, but they identify as male. In their identity, when they look and understand and how they think about themselves, they know that they are male. And so we don't see actually adults suddenly coming out and saying, oh, I was cisgender, now I'm transgender. Adults who present as transgender or come out as transgender will often tell that they've always known something was different, but they didn't have a name to give it, because this is something that is biologically ingrained. So as medical science, we've had to take responsibility for this, and as we have done with homosexuality, we've had to depathologize a lot of what we've been doing in the past. So typically in human society, if we are uncomfortable or fearful of something, it becomes a moral thing, you're not allowed to do it. Then we make it a crime, put it in our law system, and then we put it in the medical textbooks and it becomes a disorder. And so we have progressively been taking it out of all the textbooks. So for example, in 2013, we took it out of the DSM-5, where it used to be called gender identification disorder. In 2018, it's been taken out of the International Classification of Disease. Look how recent that is, right? And then importantly, the WHO Assembly on the 25th May of 2019 actually made as a health scientific community, made very clear that being trans or gender diverse does not mean to suffer a mental disorder, and we understand this as part of gender diversity. Just as we have a whole range of different races, we also have a whole range of different sexual orientations and gender diversity. So this brings us a little bit to what we had to do with that as medical doctors. So one of the challenges which Eric has highlighted is that we have noticed that we have these very vulnerable populations that have much higher rates of HIV than other populations. So we're sort of winning the fight with HIV, and we're managing to address all our different risk factors, but then we have particular key populations, of which adolescents are one. And then if you intersect that, for example, with men who have sex with men or sex workers or transgender, then those risks become very, very much higher. And so we had in South Africa a specific national strategic plan that said by 2022, we need to have plans in place on how we're going to address these issues. So the HIV Clinician Society specifically took on the issue of how are we going to help our transgender population. And what we looked at in the evidence is why has transgender people got such higher risks of HIV? And Eric alluded to that, because it's clear it's not really about sexual behavior. They're not sexually very different from cisgender people. The biggest reason why we see such high risks is because they do not access care. They do not come for HIV testing, they do not come for contraception, they do not come for condoms, they do not come after they've been assaulted, they do not come for their mental health problems. And with some of the big studies that was done in KZN, we found that the biggest issue was the attitudes of healthcare workers. So because of the way people were treated when they came to the clinics and how they were treated within their communities, they were not accessing care. And so in 2021, in response to this, in October, this guideline was released in South Africa, the Southern African HIV Clinician Society Gender-affirming Healthcare Guideline. And it looked particularly at the evidence, and it saw that if we provide gender affirmation, and I'll talk about the whole broad range of gender affirmation, we can actually really improve outcomes for TGD clients, and there's a lot of evidence on that. And we also know that if we do not affirm them, if we do not look after them, then they actually can be very damaging and harmful to our patients. And so they created this amazing evidence-based guideline, And what's extraordinary about this guideline is the amount of people who get involved. It wasn't just a couple of specialists who sat down and wrote a guideline. They really involved a whole range of different NGOs, organizations, activists, transgender people to actually be involved in creating this extraordinary guideline. And one of the reasons why you can see it's extraordinary is the whole first chapter looks at values that underpin these guidelines. And the most important value there, for me, this is a value that we should have as a communities, is that of affirmation. Affirmation is being able to look at the person in front of you, whether it's your client, your patient, a community member, and to accept and affirm them for who they are, no matter how different they are from yourself. And I think if we lived like that as a community, we would be a slightly better world. So this brings in obviously principles like dignity within the consultation, equity, recognizing that there might be different and increased needs in those communities, including them in our decision-making about their lives, and very much working on an informed consent model. So we're moving away from this gatekeeping idea of I, as the doctor, will decide how trans you are. We affirm our clients for who they are, and we give them enough information to make an informed decision about the options out there. And we've even been able to show the context of this within the ethical principles within healthcare. So when we talk about gender affirmation, everybody thinks of surgery, but actually that's a very small aspect of what happens in terms of helping transgender people feel safe within our facilities. And in the context here, and in the context where you might not have access, for example, to hormones, social affirmation is probably the most important thing you can start doing from tomorrow in your own facilities. Social affirmation is being able to say, I will use your correct name, I will use your correct pronouns, I will make an effort to create an environment in my clinic that is friendly and safe to you. And being able to just we've created posters, for example, I work in a big family medicine outpatient department, and we have safe space posters on the walls to ensure that our queer community feels safe when they visit the hospital. Now, the domain is that of psychological domain. So we've just brought out a statement at the Psychological Association of South Africa around conversion therapies. So these are either churches or religious groups or cultural groups or psychologists trying to convert people from being gay to straight or transgender to cisgender. We know that it doesn't work, and it carries a high risk of suicide. And so therefore, medically, there is now a strong move across many countries in the world to ban conversion practices, and psychological care needs to be affirming. So medical, so we have access to this in South Africa, so that includes hormone therapy, it includes talking about reproductive options, it includes things like voice and communication, involving occupational therapists, and helping people to feel more at home within their bodies. And in South Africa, the legal framework is all just focused on things like trying to change your gender marker or trying to change your names. Home affairs is a whole nother story. But of course, in many countries in Africa, as we know, we are talking actually about legal protection rights for transgender people. They need to be safe, and we need to look after the most vulnerable people in our society. So when we look at gender-affirming healthcare, it's something that comes part of a primary care practice package. So it's actually provided by the primary healthcare physician in the clinic or in the community. It's actually hormone therapy is available in our essential medical list in South Africa, still under the tertiary EML. We're busy working getting it into the primary healthcare EML. But part of that is having nurses that then provides a comprehensive primary care package. If there's a problem, we can refer, for example, to an endocrinologist, and our physicians in our area is still there as our specialist backup, although hormone therapy, I must say, is very safe and effective. It's like prescribing contraception. It's a bit of a non-issue. But with adolescent care, we do like to involve the specialist team. So with adolescents, most adolescents, transgender adolescents, the most important thing they need is social affirmation. So that is step number one, and that's something that we can do in every single facility that we're at. In terms of accessing hormones and puberty blockers, it's always one of those very emotional issues when people discuss transgender rights. But when you look at the child in front of you, it's very much a multidisciplinary team that works with that child and the family over a period of time to figure out what's best for this child. And some of these transgender children are little, scared, vulnerable kids with high anxiety, high levels of depression, extreme self-harm, high risk of suicide, extremely gender dysphoric, and our priority is doing what is best for that child. and that happens as part of an informed consent process. So part of the package then that gets provided within the primary healthcare, so we then provide gender-affirming healthcare by the social, or even if you have your hormone therapy, when the child comes in, that gives us the possibility to then provide pre-exposure prophylaxis, do our HIV testing, talk about STIs, talk about condom use, talk about fertility and contraception as is appropriate. And then very importantly with our transgender children, they have much higher risk, as Eric was highlighting. And please note, this risk is not inherently because they're transgender. These are risks created by the challenges that we have due to stigmatization. So screening for violence, there's a higher risk of them having gender-based violence, there's a higher risk of mental health problems, and there's a higher risk of substance abuse, and we need to look at that and create services for that. So as a last little plea, on the top there you'll see those two kids there are my two children, the eldest one in the front there and my youngest in the back. So my youngest child, when he was 12 years old, was diagnosed with type 1 diabetes. It's a bit like HIV. It's a complicated disease. If I had to choose between HIV and diabetes for my kid, I'll choose HIV any day. We're on 5 injections a day, plus massive no carbs. Try and do that at your next birthday party. And so we went through a couple of years where he was going through puberty, and it was really rough medically. You have a lot of doctor appointments, and you have to interact with a lot of healthcare clinicians. At about 2 years after that, my eldest came out as non-binary, and my boy came out as trans boy not long after that. And we had this challenge of finding our doctor. It wasn't just about somebody that knew about diabetes. I needed to find somebody that would love and affirm my child. So I feel very strongly about this. And how do we create safe spaces for these children so that we can also look after their normal medical needs and not just in terms of these key populations? That code there is a little YouTube video for people who's got family members that are trans or wants to know more about it. Thank you very much.
Thank you, Dr. Muller, for that passionate plea to all of us as a scientific community and as activists. It is indeed heartfelt. And this shows the power of that advocacy of having people on the inside. We've come a long ways from the days when a doctor asked me to be his special case for presentation to the faculty when I was searching access for care 100 years ago. So thank you for creating that space. And with that said, I'm going to call on our last presenter. Hendji, if you could please take the platform. Thank you.